Dear students, Assalamu alaikum. The objectives of today's lecture are to learn about obligatory urine volume, urine specific gravity, and formation of concentrated urine. Let's first study the obligatory urine volume. The minimum volume of urine that must be passed with a maximal urine concentrating ability of 1200 milliosmoles per liter is called the obligatory urine volume. Obligatory urine volume is calculated as 600 milliosmoles per day, which is the amount of solutes that a normal 70 kilogram human must excrete each day, divided by 1200 milliosmoles per liter, which is the amount, the maximal urine concentrating ability of the kidney. This is equal to 0.5 liters per day, which is the minimal volume of urine that must be passed. This minimal loss of volume in the urine contributes to dehydration along with water loss from the skin, respiratory tract, and gastrointestinal tract when water is not available to drink. Now here a question worth mentioning is that why does drinking seawater cause dehydration? Now the sodium chloride concentration in the oceans averages about 3 to 3.5%, with an osmolarity between about 1000 to 1200 milliosmoles per liter. So this means that drinking 1 liter of seawater with a concentration of 1200 milliosmoles per liter would provide a total sodium chloride intake of 1200 milliosmoles. Now, if maximal urine concentrating ability is 1200 milliosmoles per liter, the amount of urine volume needed to excrete 1200 milliosmoles would be 1 liter. But the kidney must also excrete other solutes, especially urea, which contributes about 600 milliosmoles per liter when the urine is being maximally concentrated. Therefore, the maximum concentration of sodium chloride that can be excreted by the kidneys is about 600 milliosmoles per liter. Thus, for every liter of seawater drunk, 1.5 liters of urine volume would be required to rid the body of, number one, 1200 milliosmoles of sodium chloride ingested in the seawater and of 600 milliosmoles of urea. Now this would result in a net fluid loss of 0.5 liter for every liter of seawater drunk, resulting in dehydration. Coming to urine specific gravity. Urine specific gravity is used in clinical settings to provide a rapid estimate of urine solute concentration. So, the more concentrated the urine, the higher the urine specific gravity. Urine specific gravity is a measure of the weight of solutes in a given volume of urine. It is determined by the number and size of the solute molecules. In contrast, the osmolarity is determined only by the number of solute molecules in a given volume. So, in most cases, urine specific gravity increases linearly with increasing urine osmolarity. This figure shows the relationship between specific gravity and osmolarity of the urine. Urine specific gravity is generally expressed in grams per milliliter, and in humans it ranges from 1.002 to 1.028 grams per milliliter, rising by 0.001 for every 35 to 40 milliosmoles per liter increase in urine osmolarity. Now, this relationship between specific gravity and osmolarity is altered when there are large molecules present in the urine, like the glucose or the dye radiocontrast media or some antibiotics. So, in these cases, urine specific gravity measurements may falsely suggest a highly concentrated urine despite a normal urine osmolarity. Now let's study the formation of concentrated urine. When there is water deficit in the body, the kidney forms concentrated urine by number one, excreting solutes, and number two, by reabsorbing water, thus decreasing the volume of urine. Now, there are certain requirements for excreting a concentrated urine. And these basic requirements are: number one, a high level of antidiuretic hormone, which increases the permeability of the distal tubules and collecting ducts to water, allowing these tubular segments to reabsorb water, as we have studied in the previous lectures. The second basic requirement is the high osmolarity of the renal medullary interstitial fluid. And this high osmolarity provides the osmotic gradient necessary for water reabsorption to occur in the presence of high levels of ADH. So The two basic requirements are number one, high level of ADH, and number two, high osmolarity of the renal medullary interstitial fluid. The renal medullary interstitium surrounding the collecting ducts is normally hyperosmotic. So, when ADH levels are high, water moves through the tubular membrane by osmosis into the renal interstitium, and from there it is carried away by the vasa recta back into the blood. The process by which renal medullary interstitial fluid becomes hyperosmotic involves the counter current mechanism. So now let's study what is this counter current multiplier mechanism. Counter current multiplier mechanism is a process in which there is number one, repetitive reabsorption of sodium chloride. Repetitive reabsorption of sodium chloride by the thick ascending loop of Henle. By the thick ascending loop of Henle. And number two, there is continued inflow of new sodium chloride from the proximal tubule into the loop of Henle. So, this is a process in which these two events are occurring. So, this mechanism depends upon the special anatomical arrangement of the loops of Henle and the vasa recta. Collecting ducts also play a critical role in the countercurrent mechanism. Countercurrent mechanism produces a hyperosmotic renal medullary interstitium. The osmolarity of interstitial fluid in renal medulla may increase progressively to about 1200 to 1400 milliosmoles per liter in the pelvic tip of the medulla. This means that the renal medullary interstitium has accumulated solutes in great excess of water, or simply it has accumulated more solutes than the water, the medullary interstitium. Now, there are certain factors which contribute to this buildup of solute concentration, and the major factors that contribute to buildup of solute concentration into renal medulla include the following. Number one, active transport of sodium ions. Active transport of sodium ions and co-transport of potassium, chloride and other ions. So this is the first contributing factor in the buildup of this solutes in the renal medullary interstitium. The second contributing factor is the active transport of other ions from the collecting ducts into the medullary interstitium. third contributing factor is the facilitated diffusion of urea. Facilitated diffusion of urea from the inner medullary collecting ducts into the medullary interstitium. From the inner medullary collecting ducts into the medullary interstitium. This is known as the recirculation of urea, and we'll study when we'll come to it. Fourth contributing factor is the diffusion of small amounts of water from the medullary tubules into the medullary interstitium. But this is not a very significant factor. Now, there are certain characteristics of the loop of Henle that cause trapping of solutes in the renal medulla. So, the special characteristics of the descending loop of Henle. Let's first study the special characteristics of descending loop of Henle. As this segment is very permeable to water, the tubular fluid osmolarity quickly becomes equal to the renal medullary osmolarity, because water diffuses out of the descending limb of Henle into the interstitium, and the tubular fluid osmolarity gradually increases. The special characteristics of thick ascending loop of Henle is the presence of the sodium-potassium 2-chloride pump, which causes active transport of sodium and co-transport of potassium and chloride into the renal medullary interstitium. The sodium-potassium 2-chloride pump establishes a gradient of 200 milliosmoles concentration between the renal tubular lumen and the renal medullary interstitial fluid. So this is a very important point to remember, that the sodium-potassium 2-chloride pump establishes a gradient of 200 milliosmoles between the tubular lumen and the interstitial fluid. And thick ascending limb being impermeable to water, the solutes which are pumped out, they are not followed by the osmosis of water. So, keeping in mind these characteristics of the loop of Henle, let's now discuss the steps involved in causing the hyperosmotic renal medullary interstitium. Step 1 is, as you can see in the opposite figure, is that the loop of Henle is filled with the filtered fluid with an osmolarity of 300 osmoles per liter, which is the same osmolarity as that of the proximal convoluted tubule. Step 2 is the active pump of thick ascending limb establishes a 200 milliosmoles per liter concentration gradient between the tubular fluid and the interstitial fluid. And you can see in the figure that the pump present in the thick ascending limb establishes this 200 milliosmoles per liter concentration gradient. Step 3. The tubular fluid in the descending limb of loop of Henle and the interstitial fluid quickly reach osmotic equilibrium because water moves out of the descending limb, and therefore the interstitial osmolarity is maintained at 400 milliosmoles per liter. Step 4. Additional flow of fluid into the loop of Henle from proximal convoluted tubule occurs because additional fluid is being flown into the proximal convoluted tubule, and this causes the hyperosmotic fluid formed in the descending limb to flow into the ascending limb. Now, once this fluid is in the ascending limb, additional ions are pumped into the interstitium with the interstitial fluid osmolarity rising to 500 milliosmoles per liter because the pump there is maintaining this osmotic gradient difference of 200 milliosmoles per liter. So once again, the fluid in the descending limb reaches equilibrium with the hyperosmotic medullary interstitial fluid, and as this hyperosmotic tubular fluid flows into the ascending limb, still more solute is pumped out of tubules and deposited into the medullary interstitium, maintaining the osmotic gradient difference of 200 milliosmoles per liter at each level of the renal medullary interstitium. So these steps from 4 to 6, steps number 4 to 6 are repeated over and over again, eventually raising the interstitial fluid osmolarity in the deeper parts of the renal medullary interstitium to 1200 to 1400 milliosmoles per liter. I stop here to end today's lecture, and we will continue with this formation of concentrated urine in the next lecture.